Today's webinar is part 3 of our Clinical Judgment webinar series titled Clinical Judgment in EMS, presented by Jeffrey Anderson. Jeff, thank you so much for being here with us today to share your knowledge and experience with us, and we look forward to the presentation.
Thank you. Glad to be here. Okay, well, the purpose of this webinar is to talk about how we can incorporate clinical judgment into EMS and into our educational programs. So this is what I'm going to talk about today. Number one, we're going to talk about how the field diagnosis guides patient care. Then we're going to discuss the clinical judgment model, which explains how EMS clinicians think on a call. Then we'll talk about incorporating clinical judgment into our curriculum. And then lastly, we'll talk about some specific things related to that when it comes to teaching students how to recognize and process cues. So first of all, as the slide says, the field diagnosis guides patient care. I know there's been a lot of debate and a lot of noise and heat and movement on the issue of whether or not we diagnose or not. And some of that is a bit political, and it's about our standing as a profession. And that's not necessarily bad, but that's not really what I'm talking about here and today. I think it's very important that we acknowledge that the conclusion that an EMS clinician comes to that guides their care is in fact a diagnosis. The reason for that is because there is a ton of literature on diagnostic error, all of these different aspects of thinking our way through patient encounters, and we need to be a part of that. We need to be part of that conversation. I know Dr. Maya Dorset wrote a really good article about diagnostic error a while back for the NAMSP blog, and if we get fixated in our minds that we don't diagnose and we don't need to be reading about stuff like that, we miss out on a ton of really important stuff that needs to be in our profession and in the education for our providers. So that's why I think it's so important that we don't shy away from this word. We need to understand the word, though, is a big part of this. Diagnosis is not a single event. It's a process. It starts from the family, trying to figure out what's going on. They call us. We're participating in that process, and then they get to the hospital, and then even maybe through several different layers of hospital care before a final diagnosis is reached. But all along the way, clinicians are coming to conclusions about what's wrong with the patient in front of them, and they're acting on them. And so it's important to recognize that this is a process. It doesn't stop just because I think I know what's going on. I could be wrong. And so we need to be open to that. And so again, thinking of it as a process and as something that gets revised is very important. Which is my next point, that every diagnosis is subject to revision as time passes and as more information becomes available. We've always taught our students to reassess your patient, and then that reassessment should lead to further action, further decisions, further conclusions about what's going on. Sometimes the diagnosis doesn't reveal itself right away, and so either time passes or we provide care and things become clearer, and the path we need to take becomes clearer. So we need to be open to that. And I think it's important for us to understand that in educational programs, because in the past, I know I'm completely guilty of this. I have structured my scenarios and the experiences I try to give my students around a finite conclusion. And once they've reached it, we kind of stop whatever we're doing. And that's just not the way real patient encounters work. And so acknowledging this concept and then incorporating that ambiguity and the way things change into the experiences we give our students is going to prepare them for the real world a lot better. The field diagnosis is what I call, the diagnosis that we come to. It's the organizing principle that leads and guides our actions, it's very important for us to understand that. One of the things that's always frustrated me about this argument over whether we diagnose or not is you have people that are against that concept, but then they can't explain what we actually do. When we work a call, we gather information, we take action. The thought of a paramedic putting tubes into people or putting drugs into people or doing other invasive things without a coherent idea of what they think is going on just scares me. So this whole notion of we just treat symptoms, well, we do some pretty invasive, scary things to just treat symptoms. And so I think we need to get away from that thinking. And if we acknowledge that that the conclusion we come to is a diagnosis, and that we are allowed to come to a conclusion, and that that conclusion may evolve over time. We're seeing things how they really are, I think, a lot better. And another thing that I think is important for us as educators, or if you're a training officer at a service or a medical director, if you have a provider or a student that does poorly on a call or a simulation, being able to identify what they thought was going on is the place you want to start. Because most of the time when somebody makes an error, there's a knowledge deficit, or they misinterpreted a cue or something else. And the place to start is, well, can you explain to me what you think was going on here? And then explain to me how you got to that process. You got to that conclusion. Sorry. So what information did you process to come to that conclusion? And then once we can get that out in the open, usually fixing the problem is going to be pretty easy. So again, if we train our clinicians to be afraid to voice the conclusion they came to because we don't diagnose, we miss out on the opportunity to teach and to correct and to make things better. So these are reasons why I think it's important we say that, and that's enough of that. So the next topic I wanted to talk about is the clinical judgment model. Now, this is a model, so this is not a proscriptive. The gods of the registry didn't send this to us on a stone tablet and tell us we have to do nothing but this. That's not what this is. What happened was a group of experts got together and tried to just model how do clinicians process through a call? How do EMS clinicians process their way through a call? And then they put it in a graphical format, which we're gonna look at. So it was published in Pre-Hospital Emergency Care, our journal, or one of our journals. And you can see there, it's a pretty heady group of people that were responsible for this: EMS physicians, EMS educators, paramedics, a psychometrician. I mean, so this was a lot of work by some really smart people. So here's the model. And so you can see the model encapsulates the entirety of a call. And so let's start at the top first. So you've got dispatch, which I think it's really important that we include dispatch into this, because that's where the clinical decision making and the clinical judgment starts. What am I dispatched to? Now, we all know that what we end up finding at the call may not necessarily be part of dispatch, but whatever we're dispatched to, that primes us to think about what we're going to get, what we need to ask, what we need to look for on the scene. I'll give you an example of a conversation I had with my students the other day, that if they get dispatched to a seizure, to somebody passing out, syncope, or to cardiac arrest, they need to have those three things grouped in their mind together. So if you hear one, you think of the other two, so that when you arrive on the scene and you're trying to figure out what's going on, keep your mind open for all of those, because we've all had those calls where somebody really had syncope, but it was dispatched as a seizure because the person that called 911 saw somebody fall to the ground and twitch, and that's a seizure. We've also seen cardiac arrest calls start the same way. There's YouTube videos of people collapsing during sporting events, and it's kind of frustrating to see how long it takes the clinicians to get to the conclusion that this is a cardiac arrest. And part of that is how we're primed when we begin. And so think about dispatch, and there's nothing wrong with creating scenarios where the dispatch information does not end up being correct, or maybe it's kind of misleading, because we see that in real life. And so we want to incorporate that kind of ambiguity and that kind of reality into what we do. But now, don't go crazy with that. Obviously, we need to try to make it as realistic as possible. But that's one of the advantages of having experienced clinicians run our programs, is we've all seen this. We've all experienced this. All of us have a storehouse of experiences we can draw from to add this kind of thing to our education. So the next phase is the en route phase. So we've been dispatched. Now we're en route to the call. Again, there's a lot of clinical judgment that happens en route. You're listening to the radio about the people that have already arrived. You're hearing reports about what's going on there. You're starting to figure out how many patients there are going to be, what their ages are, how sick they are. We all know sometimes that information is not correct either, but at least it gets us thinking. And so Then you've got the scene phase where we're actually on the scene taking care of the patient. And then you've got the post scene phase. Either you've gotten a refusal or you're transporting, whatever it happens to be. Now, if you notice, the next line down is clinical judgment. And what the model shows is that we are exercising clinical judgment from the beginning of the dispatch all the way to the end of the call. And I would argue even a little bit after the call as we're processing what happened and we're trying to learn. But the idea is that there's never not a time there's never a time when we are not exercising clinical judgment as a clinician throughout the call. And so the next thing is leadership. And I think we all know how important that is. Any paramedic program that sent students out into the field, one of the biggest complaints we get is our students can't run the calls. And it's a lot less about the knowledge they have, and it's a lot more about being in the middle of things, making things happen. And so that is a part of clinical judgment, understanding what's going on, directing the team in performing the tasks and moving in the direction we need to go. And that's a leadership function. Communication, vitally important also. It doesn't do a lot of good for us to keep our clinical judgment in our head and not share it. One of the ways we lead the team and we get things to go in the direction we need to go, and we get everybody on board with us, is to explain what we're doing and why, including to the patient, but to everybody else too. So communication is vital, and if we are not able to communicate effectively, that can affect everything else. Okay, and then at the bottom, you've got patient cues, environmental cues, and provider factors. So the cue is really the key piece of information that we're gathering here, and it's not one cue per call. There's dozens or hundreds of cues per call. A cue is anything that is relevant to this particular patient encounter. And this particular phase of the patient encounter. It's a piece of information that we would then analyze in order to make a decision. So you'll notice there's 3 circles in the middle of this. They say the same thing, so we're doing the same process in each phase of the call. So let's talk about the circle. It probably has a fancier name, but the name escapes me, so we'll just call it the circle. So the first phase of this process is to recognize that a cue is there. So if you miss the cue, if you don't look at the skin, or you don't look at their pupils, or you don't look at their actual breathing rate versus the 12 somebody charted, then you may miss an important process that's going on and something that needs further attention. And that would be the next phase. So you recognize there's a cue present. Now you're going to analyze that cue, and maybe it's a collection of cues together. That's possible too. But the point is, now you're analyzing it. You're trying to figure out what these mean, how are they relevant. So it's not enough just to have a number or a physical exam finding. We've got to attach significance to it. What does this mean? Does this mean I'm on the right track? Does this mean I'm not on the right track? Does this have a bearing in how sick or unstable the patient is? Is this going to help guide me toward what the correct field diagnosis is going to be? Um, all of these things are very important. And it could be something simple like, okay, I have a pulse oximetry reading. That's the cue. Can I believe this reading? Now, if I just pulled somebody out of a house fire and it says 100% and they're unresponsive, maybe I'm not going to believe that cue. Maybe I'm going to attach a different significance to it. If I have someone complaining of chest pain and I do a 12 lead and there's no ST elevation in any of the leads I'm actually looking at, can my analysis accurately conclude that no, they're not having a heart attack? Well, no, obviously we can't. We know that. So these are things to think about as we're analyzing cues. Was the test or the assessment that we're doing done correctly? Does it match what we think should be going on? How does it compare to what the norm should be? These are all things we look at to determine whether what value we place on the cue. And then when we do that, we're defining a hypothesis. We're saying, okay, I think this means this. So I think the person that was pulled out of the house fire with the O2 sat of 100 is actually probably hypoxic because of carbon monoxide poisoning. And so then that's my hypothesis. Now, could that hypothesis be wrong? Absolutely. Can we change it? Absolutely. And that word gets a lot of pushback from people because they think it means we're experimenting or We're not being certain. But my counter to that would be, number one, in the real world, there's often a lot less certainty than we would like. And so getting people used to that is important, because when you first start out with an undifferentiated patient and you're having to try to sort out what's going on, there's not a lot of certainty. Now, hopefully the level of certainty increases over time. The more information you get, the more you see how the patient responds, things get better. But just saying, I think this is what's going on, that's a hypothesis. And so a common term in the diagnostic literature is hypothesis testing. It's this whole idea of, I've gathered information, this is what I think it means, and now I'm going to act on it. So the next phase is to generate solutions. There may be multiple different ways to approach your hypothesis, what you need to do. So you'll decide what you need to do to act on this, and then you'll take that action. And then, as important as everything else, you're going to evaluate that action and the results of the action to determine whether or not you were right, number one, or wrong, or maybe you can't tell between the two based on just this one thing. But you're seeing how the patient responded. You're seeing if things changed because of your action. One of the examples I like to teach my students of this, because we always want to include patterns that they might see, is when you've got somebody that's having an asthma attack. So you get to the scene, you listen to breath sounds, and normally you expect to hear wheezing, but maybe you don't hear anything. Maybe you hear very little air movement at all. And sometimes that's complicated by the fact that we work in a noisy environment. So you have a patient, you're not sure what you're hearing because it's noisy, but you know you don't hear any wheezing. And so you're having to process what that means. And so let's say we go ahead and we give a breathing treatment anyway, because we know they're asthmatic, we know they're having trouble breathing. And then when we reevaluate, all of a sudden we hear a lot of wheezing. So what do we do with that? We repeat the process over. Now the cue is, there's wheezing when there wasn't really any wheezing before. What does that mean? And so the process can repeat over and over for the various cues. But the evaluation is important, because if I didn't reassess those lung sounds, I may see a patient who's still struggling to breathe, but that one piece tells me I'm on the right track and I should continue. So all of these steps are very important. You really can't skip any one of them and get the right picture and get the movement in the right direction. Okay, some habits of mind I wanted to include in here just because I love these, and it's something to think about as we're designing our instruction and how we're providing patient care. Occam's razor says that with all things being equal, the simplest solution tends to be the best one. I think that's something to keep in mind, that, as people are learning, sometimes they want to drift into the exotic, and um, that's not what we see mostly. So common things being common, we need to be sure we prepare our students for that. But to balance that out, one of my favorite sayings in medicine is Hickham's dictum that says the patient can have as many diseases as they dang well please. So we do see patients that have multiple problems going on, and we would want to prepare our students for dealing with that. I would not have a scenario with multiple problems at the very beginning. I would put that later in my training, so that we're confronting them with that after they've got a good view of the basics. But they do need to come out of their training prepared for that scenario where maybe the patient has multiple things going on, and we have to decide what's going to be the most important. The classic example of that is somebody who's unstable with bradycardia and they're having an inferior STEMI. Well, what do we do first? What are our priorities? These are the kind of decisions they're going to have to make. Should that be the first STEMI scenario they see in the lab? Absolutely not. But should they see something like that before they graduate? Absolutely. So both of these things can be guiding our training and our curriculum. And then again, when you hear hoofbeats, think of horses, not zebras. The reason why I think we all need to be aware of this phrase is because it's so common in the diagnosis literature, talking about looking for zebras versus horses. And so again, it's the whole idea of common things being common. So if every single scenario that your students treat is a drastically unstable patient who's on the verge of death, and that's all they come out of school knowing how to do is snatch people from death, that's not going to be what they do most of the time. And so we're not preparing them for the reality of the scenario, of the work situation they're going to find themselves in. So we definitely should have some zebras in there, but they need to see a lot of horses too, so that they get a clear picture of what the job is going to be like. I see this a lot when I prepare my students for static cardiology, is no matter how benign and stable the patient is, they want to just do everything. They'll cardiovert sinus tach at 110 because, oh, they're unstable. Well, no, they're not. Their blood pressure's good. They're in sinus tach. Cardioversion is not going to help there. But so it's you just got to practice that way so that they don't automatically assume the worst and go for the most invasive. Okay, take home point 3. Clinical judgment should be taught throughout the curriculum. Kind of touched on that already, and we spoke about that in the last webinar too. But I think this is vital. We need to be thinking about this. This is not a one-off lecture that they get and then we move on. This is something they're taught explicitly, but then we incorporate it in our feedback, in the way we teach them, in the lab, in the classroom, in the field, wherever they're learning. We need to be constant. It's like a meta curriculum. It stands above everything else. And everything should come back to how they think about the information that we're covering that particular day. I shared this quote last time. It's from Stephen R. Covey. It's appropriate for thinking about designing your entire curriculum, but it's also appropriate for thinking about designing a particular scenario or a block of instruction that you're going to perform on a topic. Think about how the student is actually going to use the information that you're giving them, or you're testing them on, or you're running them through the simulation. One of the things that I think is important is that when you write a scenario, whether it's going to be used in class or on a test or in lab, the scenario needs to have a specific diagnosis in mind. And then things should come back from that. How do people with that diagnosis present? Are there unusual presentations, not just the classic presentation? I think sometimes, and I was very guilty of this when I was a younger instructor, is I would write a scenario with a specific end in mind. And sometimes I had to sacrifice reality somewhat to get to that end. But that's not really helping our students become better clinicians. And so we need to think about how real patients with real problems, real diagnoses are going to present and how they're going to respond. And then always keep that in mind as we prepare what we're going to take the students through. I saw this quote on Twitter years ago that has always stood with me. Student, you do not study to pass the test. You study to prepare for the day when you are the only thing between a patient and the grave. And this was for physicians, but I think it applies to us too. And again, the idea is we're not teaching them the registry way or whatever way we've imagined is important. We're teaching them to be the clinician that provides care to a person with a specific disease or a set of diseases or problem. And so we always need to keep that in mind. And I know sometimes that can be difficult to do because we just have so much we have to get through. There's so much stuff we have to document. But again, as much as possible, let's keep this in mind. This is something I absolutely despise hearing, and even my own faculty sometimes say it, and my students think it. And this notion that there's a book way or a registry way versus the street way, there should be one way: good patient care, period. And one of the reasons I think this comes up is because we tend to present information, and we tend to practice and test them on the classic presentations of diseases and a very narrow, the most common type of stuff. And sometimes we don't make it as realistic as we probably should be, but still we should be teaching them the way that they will actually do it in real life. We should be modeling good clinical judgment because we have good clinical judgment. And as we're explaining why you think about things the way you do or how you would approach a certain patient, we need to talk about that. And we don't ever need to say, we'll do this for the test, but then do this in real life, because that just shoots you down right there. No one wants to listen to what you're saying after that. They're going to wait and learn the real way from their partner or from somebody else. And that's not good. We need to make sure that our curriculum is infused with reality, with here's how this actually works, and make sure we present it that way and help the students understand that. Another thing that I think is very important is the eye cannot see what the mind does not know. And so, number one, this is a call for a knowledge-rich curriculum where we're covering as much as possible, and we're covering it in a way that the students will learn it and remember it. But also, I think it's a good argument for scaffolding when we're creating our instruction and we're mapping all of this out. We need to make sure that we're not throwing a bunch of stuff at the students they haven't learned yet. And so that can be very frustrating for them. So I think, for many reasons, we want to scaffold how we do this, where we provide a lot of support on fairly simple tasks to begin with. And then as we go along, we remove the support and we increase the complexity of the tasks. But we make sure that we've planned this out so that we're giving the students things that they can actually do, that they're prepared for, or they should be prepared for. Now, I know sometimes our lab scenarios in particular are a way that the students can find out they're not prepared as they thought they were. But as long as that's followed with a good discussion and some good feedback, I think that's okay. The goal is never to embarrass, but it's to learn. Another factor that kind of relates to what we've been talking about is this is a quote from Dr. Amal Mattu. He's an excellent physician, emergency medicine educator, mostly known for EKG, but there's a lot of other stuff too. He's taught. He's amazing. One of the things that's always stuck with me is his quote here, where he says, "Classic presentation is Latin for 15% of the time." And I know, thinking about when I've created instruction on various diseases or problems, I have tended to gravitate toward what we consider the classic presentation, and we haven't given the students an accurate picture of all the different ways this could present. There was some research on anaphylaxis done a few years ago where our students did a good job, and EMS clinicians in general did a good job identifying anaphylaxis when it was basically slapping you in the face saying, "Hey, this is anaphylaxis." But there were alternate presentations of anaphylaxis that we weren't getting because we probably just had never been told. And so, thinking about whatever we're talking about, how does this present? How does this look in real people? And what are some of the different ways it can present too? So we're not just doing the one thing. Because another quote that isn't directly attributed to Dr. Mattu, but you hear it all the time, is the patients don't read the textbooks. So we don't need to make every single our students encounter a textbook case, because all we're going to prepare them to do then is treat the textbook and not real people. Which, and if you think about it, all of this focus on clinical judgment, that's one of the main pushes behind this. And the reason we need it so much is we're trying to get people to be able to take care of real people in real situations, which requires a lot of judgment, a lot of analysis. Uh, Something else to think about is when you're trying to come up with your activities related to this, remember the difference between formative and summative. Formative are meant to teach, summative are meant to test, not always the same thing. With formative, we're going to provide more scaffolding, we're going to have more discussion, more feedback. Summative, the main purpose is to decide whether they've got something or don't have something. But one of the things I want to keep in mind here is formative does not mean easier than summative. These are independent. Formative and summative is the function of the assessment. If it's formative versus summative, sometimes there's a little bit of both. But the key is formative assessments can be very difficult. And I would actually recommend that if you're going to have some scenarios that are very challenging. Like in our program, me and my partner are both Star Trek nerds. So we have a set of scenarios we call the Kobayashi Maru scenarios. They're not intended to fail students. They just happen to do it most of the time because the material is kind of difficult. But when we do those types of scenarios, nobody fails that day. They're very low stakes. The whole purpose is to generate conversation and to give feedback. And so we'll spend an afternoon running students through scenarios that they mostly don't get, but then we're going to come back around and we're going to teach them. And we don't do these until we've covered the material needed. Part of the problem is they've got so much in their head, they didn't identify the particular thing they needed to get the scenario right. And so this helps them learn that. And so we can have a really good discussion later on about this. So again, the key thing to me is formative can be incredibly difficult. I would actually, what we've tried to do, and I'm not saying we've succeeded at this, but we've tried to sequence the scenarios that we put our students through where they get harder and harder and harder by the end of the program, our final practical and then our sense of what they're going to see at registry is actually a bit easier than what they end up with at the end of the program. So I know it's impossible to say exactly how hard registry is going to be, but we all have kind of an idea of where we think it is. And then I would definitely try to create experiences, whether it's written exams, lab scenarios, whatever it is, where you're going past that. Because the ideal is when they sit down to take their test, it's not that hard, because we've taken them beyond that. But and we've talked a little bit about this already, the concept of scaffolding. Excuse me. So the idea is that as we go through the program, the complexity of the tasks we ask the students to perform increases because their knowledge increases and their level of expertise increases. And at the same time, we are withdrawing support from them. So they're acting more and more independently. And this is where the art of teaching really comes in, because you have to, sometimes you're doing this in the saddle, when you're doing a scenario or something like that. Because if you go too far, you withdraw too much support or you ask too much of them, they just stop. They cognitive overload hits, they don't know where to go. But if you make it so easy, they're not really learning anything. So this constant push forward in their performance, it takes a good teacher to monitor that and to kind of guide it. And so even in the same scenario, you may provide different levels of support to different students, which is okay in a formative setting, because again, the main purpose is to learn. Now, eventually though, everybody's going to have to get to the minimum standard, and we don't want to compromise that. But how we get there is important. It's like that whole idea of, well, back in my day, we just threw a kid in the pool and expected them to figure swimming out on their own. Not the best strategy. You'd probably end up getting a call from somebody today if you tried to do that. And so I wouldn't throw a student in the deep end of a scenario or simulation and expect them just to work their way through it at the very beginning. But we need to build the program so we get to that point at the end. So the last point, teaching students to recognize and process cues. These slides actually come from the registry. There was some documents released when they published the fact that we were going to go to the performance items. And I think they provide really good guidance on how to teach students to recognize cues. So again, we've got the circular model of how we process the cues. And then the document actually has the 3 phases: en route, scene, and post scene. And it gives them some examples of what details the registry intends to provide to the candidate in the performance item, which we could incorporate the same kind of things into our scenarios when we write a scenario up, whether it's going to be delivered in class, whether it's going to be an oral station or a scenario in a lab or a simulation, higher level. We need to be thinking about, have a script for what cues we're going to be able to provide the students so that we can then see if they actually acted on them. So, here's some things here that we would want to have in our dispatch information in the beginning of the call, some information they would need to know. And these things could affect things like environmental settings. I have a scenario in our program that was based on a call I actually ran where, even though I'm in Louisiana, we had a winter that had temperatures close to 0. And I worked a motorcycle wreck at an intersection about 10 o'clock at night. So it's dark, it's windy, it's raining, it's wet, and the ambient temperature is about 10 degrees. And so in that case, my judgment was that the first thing we needed to do before I did anything else was get that patient in the back of my ambulance. And that's what we did, because my judgment was the environment was going to kill them faster than anything else. And I didn't really want to expose them out in the environment anyway. So we scooped them up, we put them in the back of the truck, shut the doors, turned the heat on, and then went about airway breathing, circulation, and all of that. So those details can matter in a scenario. It can change the sequencing or your appreciation of what's important. And so the crew configuration can also make a big difference. I would not have the same crew configuration for every single call that you put them through, because the way you process the call and the way you do things is going to change depending on who's there. I remember when I first moved to Bossier and I was working on the side as a paramedic for a local agency, that was the first time I had ever been on a scene with another paramedic. My partner was a paramedic. The fire department had a paramedic there. And so running a call with 2 paramedics and 3 EMTs was a very different scenario than what I was used to doing, which was having a first responder partner and maybe some volunteer firefighters. So the way I approached the call had to change a little bit. It took a little bit to get used to. That was also the first area that I'd ever worked where there was an interstate. So working a motor vehicle crash on an interstate changes things too versus a country road. And so these are the kinds of things we can incorporate into the experiences we provide our students to make them think about that. If they train on just how their department does things, double paramedic, fire engine on every call, then they're going to get used to doing things a certain way that may not be the way they end up doing them in real life. Because we all know our students moonlight, they go to other places to work part-time. And so you go from an urban fire department to a rural private service, that's going to be a different way of doing things. And so they need to have thought about that and experienced that along the way. The next section is the background enrichment considerations for the developers. And again, so you as faculty developing scenarios can use this to help you figure out what needs to be in here to have a good scenario that will be a realistic representation of what our students are going to do. And so they even list some cues to put in this phase of the call. Are there certain dispatch details that might trigger a response? Where we're dispatched to, the way it's dispatched, time pressures. Are there time pressures associated with this particular response? Environmental factors, provider factors, things that are abnormal versus normal, or seeing if they can recognize whether it's abnormal or normal would be very important. And then also there's potential items down here. So you can have an item or a question you ask the students about the dispatch information. Did they get a particular cue that you intended them to from how they were dispatched? Talk to them about their analysis of those cues that they recognized. Explain to me how that changed your thinking. Tell me what you thought was going on. Tell me what you thought this meant would be the hypothesis. And then what did that lead you to do? And then responding, evaluating that and reassessing that. So this particular template is meant for the performance items that are going to be on the National Registry exam. But as you can see, you could do the same thing in a scenario debrief. You're in the lab, you've run a scenario, ask them some of these types of questions so that we can have a conversation with them to give them feedback. Doesn't have to be a multiple choice or multiple answer exam item. It can be just part of your discussion as you go forward after a call. So the scene, this is where you get your patient information, your chief complaint, your history, all of that. Another list of cues here. So assessment cues, that's probably what we think of most when we think about cues is assessment findings, blood sugar, skin signs, whatever it happens to be. History cues, also important. Could their past history play a role in what's going on today? That's a very good question to ask a medical patient. Has this ever happened to you before? And if it has, what was it last time? Or are things different? You're thinking maybe your patient has a subarachnoid hemorrhage because of the way they're presenting today. They tell you they have headaches. Well, does this feel like the headaches you usually have? Did it start the way your headaches usually start? These are not black and white issues, but it definitely helps us figure out what's going on with the patient and get a sense of where we're going. Medical records and artifacts. So if you're having a scenario where there's a transfer, or maybe you're responding to a nursing home, there could be a patient's chart or a med list or something like that. Or maybe it's a home health patient with those documents. So the patient themselves can't tell you a lot, but there's a binder that you made up and put in there with all the information. Do they think to even look at that? Do they interrogate that for answers? Is there time pressures involved? Maybe you've got family members there that are trying to push you into moving too fast, or there's a time sensitive illness that you've got to handle quickly. Otherwise they're going to deteriorate. So that would be a cue for the students. Do you recognize that, no, you couldn't take your time on this one? It's important that you get to an answer quickly and target your questions and your assessment to that particular problem. Environmental factors, anything with the environment, the patient's house, or it's not just temperature or weather. It could be the dog that's barking you can't hear. It could be the family members that are yelling in the background. It could be the TV that's on, whatever it is. Do they appreciate how that's affecting how the call is going, and can they take an action on it? or can they just ignore it? Sometimes that's the best answer, but we want to have them make those decisions and then eventually be able to explain them. Are there provider factors associated with this? And then again, abnormal versus normal. And so down here, potential items or questions. Obviously recognizing cues from the assessment and the history, identifying the relevant stuff. I think this is a big one because students in general tend to gather a lot of information. And one of their tasks is to figure out what's relevant and not relevant. That's how you can tell a seasoned clinician versus a new one. Is the seasoned clinician gathers less information, but it's more relevant. The new clinician gathers a lot of information and they're struggling to determine what's relevant and not relevant. And so asking questions or having discussions related to this would be very important because that's something they've got to learn how to do. Define and prioritize the hypothesis. So, coming to a working diagnosis, prioritizing what's going to happen, then generating solutions. What do we need to treat first? What's the most important? And then taking the action and then reassessing and then moving on through the call. So this would be the scene phase. Post-scene phase, again, assessment cue. So reassessing your patient. So we have a patient who has been provided treatment. How are they going to change? Are you thinking about that when you write your scenarios? Do you have a plan for what's going to change about this in the call so we can have them respond to it? And then some of the other stuff are the same. The environment can change, provider factors. Down here at the bottom talks about recognizing cues. So did they reassess? Did they perform an intervention? And then did they reassess it? Maybe you have somebody who broke their arm and, the students provide the splint like we thought they would, but now the hand is swelling and turning blue. That doesn't indicate they did anything wrong. Maybe their arm just started to swell. It's time to readjust the splint. But if they don't reassess, they're not going to know that. And so that would be a cue, the changes in the hand, or maybe the patient saying it hurts. Are they able to recognize that and then process that cue to come to the correct action? So that can happen during transport or after the initial treatment of the patient. Down here, it talks about the working diagnosis again, because that, we know a working diagnosis changes. And so if they've provided treatment and the patient's condition has changed now, how does that change affect what they think is going on? Is it changing their mind on something? Is it affirming what they already thought? And so it would be important to draw that out to get them to think about it. And maybe to have some scenarios where things do change as we go along. And then taking action, evaluating, those are pretty much the same. Again, every time you perform an intervention, it's time to reevaluate things and see where we need to go. And this should continue all the way until the call's over. So that's, I know I'm a couple minutes early, but that's basically what I wanted to talk about today is, so those are the take home points I wanted to give y'all. And then here's my contact information, and I'm happy to have any questions or discussion.